Good evening, everyone. Allison Skaberg here. We're happy to be here with you tonight. I represent ADDA, the Attention Deficit Disorder Association. We are a Sugarland chapter that in COVID, we used to meet in person. And in COVID, we moved to an online platform where we have continued to have our meetings monthly. So if you're joining us for the first time, we're absolutely glad that you're here. We do meet the first Tuesday of every month from 6:30 to 7:30. And we have different speakers that we feature every month on related topics to parenting your child with ADHD. And so tonight we are super excited to have Dr. Emily Wu with us here tonight. We are going to be talking about topics related to medication and medications related to ADHD. So this is an important topic, and I know it's one as a parent myself to an ADHD child. I know that it's an important topic and it comes up pretty regularly. So we're really glad to have you here with us here tonight. From a housekeeping perspective, tonight's webinar is being recorded. And so tomorrow, everyone will get a copy of the slides that are being presented tonight, as well as the recording. The chapter ADDA SR, it really is it's a volunteer organization that provides support to individuals impacted by ADHD. It might be a person themselves, or, a parent. Our group is a parent group, but there are other groups all over the state of Texas. And to join, we never push membership. It's not something that you ever have to join to be a member to attend these webinars. You can always attend them for free. But membership is $40 a year for a family, and they have an annual conference, and they also have other meetings, like I said, all across the state. So if you yourself are impacted by ADHD, maybe a diagnosis yourself, there are adult groups out there as well. And so the email that'll come out with the slides and the recording will have information on how to join should you be interested in joining. I will say that I have attended their annual conference in the past, and they bring speakers in from all across the country, not just in the greater Houston area. And very, very valuable information has come out of that over the years. So having said that, we do want to answer as many questions as we can tonight. I will be monitoring the chat box for Dr. Wu. And as we have questions, I'll bring those up to her. And as for that, Dr. Wu, thank you again for being here with us tonight. And I'm going to turn it over to you.
Hi, nice to meet everyone. Thank you, Allison, for the introduction. So as the first page Allison showing, this is my contact information. So you're welcome to contact me in the future if there's any questions after the session. So, and with that being said, and we can probably go ahead and get started. Okay, so the first slide we're talking about here is regarding to what is ADHD in terms of the things people usually see, as parents for your child. I don't know if this is a more interactive, group chat. Is anybody can comment, whether on the chat or, want to speak up of what kind of symptoms have you guys seen as parents, in the community that you feel that was being perceived as ADHD or the common symptom you see in your child or anybody else? So if anybody's interested in answering a question, Allison, can people speak up, or is this mainly just on the chat? Okay, cool. Okay, so thank you for some people answering the question. So some people say they see the hypersensitivity or jumping to the future, jumping on the furniture. Okay, chasing friends in the classroom. Okay, easily getting angry. Okay. I'm going to leave a couple more seconds, see for any other answers. Okay, impulsive. I saw people saying daydreaming or cognitive skill lacking. Okay. Sustained attention. Those are really good points. So I think, and unable to get started with homework. So I think those are really good, valid points, which you probably seen commonly in children with ADHD. So I wanted to start off with giving people a little overview of, what is composed of also ADHD symptoms. So as people probably know, ADHD stands for Attention Deficit Hyperactivity Disorder. So it involves usually two main categories. So one of the domain is inattention symptom, that's attention deficits. So a lot of times, people tend to see symptoms of not able to paying attention in classroom setting, paying attention to lectures, or paying attention in day-to-day conversations. People might say, oh, my child seems to zoom out a lot, or organizing self in terms of, okay, put your stuff back where it belongs to. Do you remember where you put your toys? Organizing time management in terms of homework or assignments, that what do you need to do first? What do you need to do second? Or even like saying, organizing your own thoughts in terms of communication. Can you clearly organize your thoughts? Okay, what I'm trying to tell my mom, point one, point two, or you seem to really scatterbrain, you're jumping from one point to another point. People be like, wait a minute, what are you trying to actually tell me? Making careless mistakes at school in terms of, say, not because my child really doesn't understand math or understand English subjects, but it's because I miss a whole page of, exam. So I didn't see there's a page 2. I completely missed that. So I didn't get a grade that I deserve. Or that I skimmed through the paragraph or reading too fast. So I didn't read through it carefully, or missed certain information because I just skimmed through the reading, because I'm not able to pay attention, or I'm impatient, so that I didn't get a grade I deserve because I answered a question wrong for not reading carefully. Constantly being forgetful in day-to-day activities. So, somebody might say, oh, I constantly can't find my key. I constantly can't find where my phone's at. The third jacket is lost at school campus, that kind of things in terms of being forgetful or easily losing stuff. And other things, including difficulty following through and organizing tasks. Say if the teacher give you a big instruction, then I just feel I'm completely lost. I don't even know where to start, or if I can initiate it initially, but then I'm having a lot of trouble wrapping things up to complete, which leading to a lot of procrastination on complete projects. So those are a lot of symptoms related to the inattention type of symptoms. Now, in terms of the H, the hyperactivity part. So as we mentioned here, so hyperactivity usually have two parts. One part is in terms of a motor hyperactivity. So that's usually the people saying like, oh man, a child is kind of like a human ping pong ball, kind of bouncing off the wall. Like somebody mentioned on the chat that jumping onto the furniture, can sit still, being fidgeting all the time, restless. The teacher might say your child has been more disruptive, can sit still in a classroom, constantly had to stand up or squirreling around, fidgeting, that kind of issues in terms of behavior or motor hyperactivity symptoms. Some might say that he tend to be blowing out the answers. I can't waiting for the turn to raising my hands, or waiting for the turn standing in a line in the cafeteria. I blow out the answer. I want to skip the line. Or somebody who talking excessively in a class, a teacher will be like, hey, stop talking to your friend next to you. It's class time. So those kind of behaviors sometimes are easier to caught in the teacher's attention in terms of a hyperactive symptom. The teacher might report to the parents, say, hey, you need to get your child tested or treated because it's getting to be too disruptive in a classroom setting. Now, the other piece I want to differentiating is in terms of the hyperactivity. Another part of that, instead of motor hyperactivity, there's also a part of the social emotional impulsivity symptoms. So what that means is sometimes the impulsivity from a social emotional perspective might be a manifestation of the ADHD hyperactive symptom too, which can manifest as somebody say, my child seems to be very short-fused, in terms of I can easily go from 0 to 100 in terms of mood swing. Like somebody commented on the chat earlier, say easily become angry, or easily being triggered. Or if you get triggered, by provoked by somebody else, it seems to have a bigger emotional reaction compared to somebody else in the same situation. Easily getting into a fight with the peers or siblings, easily to be irritated, impatient in terms of low frustration tolerance. So those can be symptoms from the social emotional impulsivity part of ADHD. And sometimes somebody can have a combined type. It means they can have both the inattention symptoms and hyperactivity/impulsivity symptoms. But sometimes for some child, they might have more predominant one part of symptom, like predominant inattentive symptoms or predominantly hyperactive symptoms. So that's in terms of the kind of a big overview of the ADHD symptoms. Next slide, please. Okay, so how do we testing for ADHD and why do we need ADHD testing? So we're going to talk about it, in a little bit. So in general, there are different type. There are different type of ADHD testing tools. So why do people need to get testing first, whether from a screening questionnaire or from a more thorough neuropsychological testing? So the goal is, number one, we want to give a perspective on the children's behavior pattern as experienced by people close to them. Usually, some of the questionnaire, as listed at the bottom, the Vanderbilt ADHD questionnaire or the Corners behavior rating scale. Those are the ones usually require a teacher report form and a parent report form. In order for somebody to be diagnosed with ADHD, it usually need to be screen positive, like I said, in either inattention or hyperactive or both, but it has to be screen positive in at least 2 different settings. That means it has to be screen positive by both a teacher report and a parent report in one or both area in order to be considered as ADHD. So we wanted, for a lot of children, especially children's age range is different. For younger children, it's hard for them to elaborate in what kind of symptoms they're experiencing. So it gives us more accurate data from the observation of people who live or stay with them day to day, such as your teacher and your parents, which is why that part of information is very valuable in terms of a diagnosis. The clinician only see your child one time as a snapshot. They don't have as much of a dynamic longitudinal observation to making those assessments without your input. We also want to compare those information with the standardized clinical information to help support the diagnosis. Sometimes some people can just not being able to pay attention. So everything is on a spectrum, right? We all have moments of not being able to pay attention, things zooming out because you're in a boring meetings, that you just feel like I don't want to be here, right? But at what point your ability not to be able to pay attention is really pathological, considered as a disorder? Or is that just a typical 5 or 6 year old who's not able to pay attention, needs your teacher to tell you, hey, circle time, sit down, right? So this is why we want to do assessment and comparing the data with the standardized data to knowing that is the symptom really meeting the clinical threshold of considering clinically positive as a symptom versus it just on a spectrum, it might be age appropriate. So this is why we need to find a baseline of the typical behavior to guide a treatment and a medication recommendation. If something really is a screen positive, depends on what kind of symptoms is screen positive and how severe it is compared to the general population, then we know what kind of treatment we can recommend accordingly. And so, that's kind of the reason why we need a testing in order to give us a better data, knowing that, what's the status of the patient and what kind of treatment will be more customized for each patient. So we kind of talk about the screening questionnaire listed at the bottom. So the first two, the Vanderbilt and the Corners, are somewhat, they're different questionnaire, but they're kind of similar, both in terms of sensitivity and hyperactivity. Sensitivity and the specificity, as I listed on this table right here. So as you can see, the Corner and Vanderbilt, both the teacher and the parent report form is all around like mid-70s to mid-80s in terms of sensitivity and specificity. So those are just the data showing that how accurate the questionnaire is used to rule in and rule out somebody who has ADHD. So, there's no right or wrong answer, but it's very clinician preference preferred, and which clinic uses which type of questionnaire. And in general, they are used for testing for the major symptom of ADHD in terms of hyperactivities, aggressive behavior, any potential for violence, compulsive behaviors, perfectionism, any difficulty in the classroom, extra trouble with the math or difficulty with the language, social issues, emotional distress, separation anxiety, things like that. Those are usually the items listed under the corner questionnaire. Very similar to corners in a Vanderbilt. The major category of things to try to screen out is the inattention symptoms, hyperactive symptoms, oppositional defiance, or conduct disorder, which is usually the behavior aspect of any comorbidity symptoms. Anxiety or depression, which could be the social emotional comorbidity of ADHD symptoms. And then lastly, on the teacher report form for the Vanderbilt, there's 3 brief items to screen any learning disabilities, which is, again, similar to the corners in terms of screening for math or language issues. So usually in the primary care physician, like pediatrician's office or in a psychiatrist's office, either Vanderbilt or corner, the teacher-parent screening questionnaire is the primary assessment tool that we use, along with a clinical interview with the parents and the students, which is the patient in the case. During the interview is how we make an ADHD diagnosis. Sometimes that the screening questionnaire might not be sensitive enough. Means that there might be a discrepancy in terms of the teacher report and the parent report, or some child may say that, my child is quite high functioning. She's still getting like straight A's, on all the exams, although she knows that she's struggling with not being able to paying attention. She knows that she might take like an hour to finishing certain homework assignments versus her peers only need 30 minutes in terms of feel distracted, not able to pay attention. She's still getting A's. So from a teacher perspective, well, she's a great straight A student, and the parents might not see those issues at home either. But the child themselves might still feeling struggling. So when those kind of discrepancy does happen, we don't want to invalidate or dismiss the experience or symptoms for the individual. That's usually why we feel a formal neuropsychological testing will be more helpful. A neuropsychological testing is not based on just teacher and parent report form. That usually has to be done by a PhD psychologist. Sometimes the psychiatrist or pediatrician can refer to a PhD psychologist to getting a neuropsych testing done, and then they can interpret in the testing results in order to confirm if this is ADHD or not, and then before starting the next step of treatment. So the neuropsych testing is a more comprehensive testing. Again, I'm not a person usually do neuropsych testing, although as a psychiatrist, we often order the testing to verify the diagnosis. It's not just based on the subjective observation from the parent or teacher, but it's a more accurate diagnosis for the ADHD learning disability through a comprehensive assessment of cognitive and behavior functions using a set of standardized tests and procedures. Some of the testing might be the paper and pencil testing, question and answers during the office visit, and also computer-based testings. Most of the testing are done by the child themselves. So they want to using those testing to looking at, different domains from a neurocognitive perspective, that including intelligence, academic performance, and that kind of even coming down to more subcategory in terms of verbal reasoning, visual spatial skills, nonverbal conceptual reasoning, working memory, attention, processing speed in terms of visual scanning and handwriting speeding, language and social communication, and fine motor or visual motor integration issues, memory and executive functionings. So it's much more comprehensive, and it's more objective in terms of the neurocognitive function than just the parent-teacher observation. So it's a different approach when things we can't screen out through just a Vanderbilt corners. We want to get into more in-depth neuropsych testing to looking at the results.
Dr. Wu, sometimes that neuropsych testing, it's been said in our community, ADHD parents, people that have kids that are high functioning on the autism spectrum, that sometimes that neuropsych testing, especially that IQ testing, is skewed because the kid's hyper and doesn't want to do the test, and the hours that it takes to do the testing, some people question that, or they've had repeated tests years later where at one point it was saying that the IQ is, in the category of an intellectual disability, and later it was not. but based off of their, a lot of our kids don't test well. Can you talk to us about that a little bit?
Yeah, so again, I'm not an expert of ADHD in terms of the neuropsych testing perspective. That's more the PhD psychologist domain. But what I can say is neuropsych testing is a big umbrella. The way the analogy I'm looking at that is to say, say your pediatrician saw your child has a cough. Right? They might do a physical exam, which is like the clinical interview we do as psychiatrists. And then sometimes they are able to confirm just based on physical, examination and listen to your lungs with a stethoscope, say, okay, you definitely have a pneumonia. Here's the medication, start a treatment right away. But sometimes they might be like, something sounds a little different. I can't confirm this is a pneumonia just by listening to your lungs. We're gonna need to order like a chest x-ray. So the chest x-ray is ordered by the pediatrician, but it's done by radiologist. And the radiologists are the people reading the chest X-ray image and put down a clinical impression. And then your pediatrician might looking at the finding based on the radiologist reading, say, okay, we're confirmed this is pneumonia, or maybe it's a lung cancer or something else. And then we're going to start treatment differently, right? So
basically you're saying that they can get to the accuracy because they're not using one mean of data to make that diagnosis. It's multiple different sources that they're pulling it together to get where they're going. It's not just one. That makes sense.
Yes, because the neuropsych testing is kind of like what I'm talking about, like a chest X-ray or like an MRI for your brain. It's a testing tool, but depends on what you're looking for. The specific testing can be done differently. So, and that is more the nuance for the person who's doing the testing, because there can be different kind of battery of testing instruments to be done. To answer your question earlier, so there is intellectual testing specifically for IQ, but if somebody having say autism as a comorbidity for ADHD, they might want to do autism testing as a part of the neuropsych testing, which is called ADDA, which usually is the gold standard testing for autism. And ADHD, like we talked about, you can do Vanderbilt, you can do Corner, you can looking at a visual spatial working memory. So what I'm saying is neuropsych testing is just a big name, a big umbrella as a testing tool. But in terms of what type of specific testing instrument to be conducted for the patient, depends on what kind of comorbid symptoms you might have. And then they will, using different testing instrument to diagnose not just ADHD, but maybe there's a learning disorder, maybe there's autism, to testing those things too as a more comprehensive picture of what's going on, if that makes sense.
Yes, thank you.
Yeah, sure. Okay. So the next step we want to talk about is, how does ADHD affecting people's school performance, and how does medication play a role in this? So based on the large cohort study, this is actually one of the largest cohort studies so far, involve a subject of 3,543 participants. So as this graph is showing you, so this is a graph showing the throughout the months of a treatment, how individuals' GPA performance has been different compared to a patient who has received an ADHD treatment, medication treatment, versus has not. So the graph for A, which is this, I guess a hollow points at the bottom, that is showing for individuals who has ADHD but did not receive medication treatment, versus the solid dot for dot B on the top is showing for individuals who did receive the ADHD medication treatment. So based on the data, we're showing that ADHD has a substantial negative impact on school performance that was independent of several important confounding factors, that including, what kind of demographic, population you're coming from, what's the parental education background, what kind of area, region, you live in an inner city or rural area, that kind of demographic information has been excluded. We're still showing that ADHD has a substantial negative impact on people's school performance. And medication treatment for ADHD has been showing a positive association with the school performance in the measurement of a GPA and standardized testing scores, as well as eligibility before and completion of the upper secondary school. That means up until high school graduation. So this is why on the graph you're showing the testing from this research study showing that the children has been receiving ADHD medication treatment tend to receive higher GPA compared to the ones did not. So based on,
is there any study out there on the medication? You're probably going to get to this in your slides, but is there any study out there on the medication and the effects of anger and aggression and increased anger and aggression or other, mental instability? So they may have good grades and that we may have like dodged that bullet, but if then there's other things going on, what's the status of those studies?
So we don't have a direct study to showing that, but I kind of see where you are coming from, like your question, like, oh, how comes those people have a better GPA? I guess that's your question, right? Like, why are they receiving medication to having better GPA? Is that because they have a better?
No. That's not what I'm saying. I guess what I'm asking is, are there any studies? So we as parents, a lot of us do understand the benefits of medication and increased focus in school and things like that. But, a lot of medications come with side effects that are sometimes worse than what the original problem and what we're taking the medicine for. And not just ADHD, just in general. But so, and we've seen families that have discussed, increased, mood lability and anger and aggression. And some of that might be what we call typical teenage behavior, right? Like as they're moving into adolescence. But others wonder if it's medication related. And I was just curious if that is being studied or if that's being looked at.
Right. So good question. We're going to talk about more about side effect in the later slides. But long story short, it could be a double-edged sword, and it's very individual dependent. It cannot be generalized as speaking. For somebody who has primary ADHD, this is why it's important to have a clinician starting the medication, right? So we want to make sure we understand what kind of comorbid issue that's already been going on for the individual before we're starting the medication. So, if somebody who primarily having just ADHD absolutely does not have any primary mood disorder, like, oh, my child is the most pleasant kid you will ever meet, always happy and bubbly, but just like very ADHD. Then sometimes, for people who are very straightforward, just ADHD with no underlying mood disorder, then we have seen people who actually have an improved mood. They're actually being happier and calmer and getting to less fight with, peers or siblings, with less anger outburst issues once their ADHD is better controlled with medication, when their impulsivity has been reduced because of medication help with that. But that being said, sometimes people who can have side effects of having more anger, agitation, irritability issues that's induced by medication. I would say the risk of that is higher if somebody does have an underlying, primary mood disorder already, like somebody already have anxiety and ADHD issues, or having a lot of mood instability issues to start with. That's not related to ADHD, but it's really its own primary mood issues, not like when I mentioned earlier on the slide, the social emotional impulsivity secondary to ADHD. So if somebody has its own, separated mood issues going on, mood disorder already, plus ADHD, we want to address the mood disorder first to stabilize their mood, because it is very possible to putting them at a higher risk of worsening their mood when you're getting on ADHD stimulant medication. And again, we'll talk about different medication options later as to what is higher risk of causing that and what our medication potentially have a lower risk for that. So. Okay. So we are on the slides of talking about stimulants versus the non-stimulants. So that's kind of going back to a little bit we talked about earlier. So, in terms of ADHD medication, there are two major categories. There's a methylphenidate category and there's an amphetamine category. That's the two major category of ADHD stimulants. In general, ADHD stimulants are the first line treatments for individual with a confirmed ADHD diagnosis. They're usually higher potency in terms of, I would say if somebody consecutively taking a stimulant medication within 4 to 5 consecutive days of taking the medication, they should start to being able to noticing whether the medication is making some improvement or not yet. And you don't have to taking stimulant medication every day. At the beginning stage, maybe you want to take it more consistently. If it's a brand new medication, you don't know if it's working for you yet, or you don't know if it's the right dose for you yet. But for somebody who's already a veteran on medications, like, oh yeah, this has been my medication for like a year, it's doing so well, I know that's exactly the right dosage, then you don't have to take it 7 days a week. If you feel like you need it on the weekend, you can. But a lot of time I give people the analogy of a stimulant medication is kind of like a reading glasses. You put it on your face when you need to read, you take it off when you don't need to read. So, and that's more like a lifestyle choice by people. Some people say I need it 7 days a week because without it, my family is complete chaos. My kids will be all over their siblings, then go for it. But some people might say, well, I think my kids only need the medication during school days when they're in school. I don't think they need it in a summer break or holiday or vacation time. That's also okay. So that's a benefit of the stimulant medication. Their higher potency means in shorter period of time you can notice a difference or not. You don't have to take it every day once you're already on a stable position with the medication. However, the side effect of stimulant medication, as we kind of briefly touched earlier, thanks to a good point brought up by Allison, is it could be leading to more mood disturbance issues because they're more stimulating. So versus this is the reason why we have a non-stimulant medication in place, is if some people having more, like we talked about earlier, a primary anxiety or primary anger, or bipolar issues, then they really are not able to tolerate being on stimulant medication. If somebody has a true bipolar disorder on top of ADHD, sometimes we try to be more cautious of starting any stimulant medication because it is possible ADHD stimulant medication might trigger people into more manic-like episodes. Or if not bipolar, just somebody with a primary, really high intensity of anxiety issues, then it is possible that ADHD medication might potentially making anxiety worse. So we don't want to treating one, problem on your diagnosis list, but making another diagnosis, another disorder worse. So sometimes those can be the things that we have to think about before we start medication. Do you have any other comorbid symptoms before we starting the medication? If somebody who really cannot tolerate stimulant medication, whether it's because they have other concurrent comorbid mood disorder, or because they really had worsening anger once they started stimulant medication, but before that, they don't have anger issue. Then again, you might truly suffering a side effect from the medication, just cannot tolerating it. That would be the time we're talking about, okay, should we consider a non-stimulant medication option? So non-stimulant medication option, usually there are a few currently on the market, including clonidine, guanfacine, or Strattera. So, the pros and cons for that. So the non-stimulant medication doesn't cover the same side effect profile as the stimulant medication. We'll talk more detail in the next slide. But in the meantime, they're not as high potency as the stimulant medication. Like we'll talk about, okay, 4 or 5 days taking a stimulant meds, you start showing an effect. The non-stimulant medication usually takes weeks. We'll say, at least 4 to 6 weeks-ish is a kind of the time window we're looking at the medication starting to making a difference. Another thing is you do have to take the non-stimulant medication in a daily basis. It's not something you can be on and off like a reading glass, as I mentioned, for the stimulants. So the purpose of that is to building a steady concentration in your blood, in order to let the medication kicking in, so it can start to showing clinical efficacy. So for those reasons, it might be slower and it's more like a commitment. You do have to take the medication every day. You don't want to skip the dosage, which might cause withdrawal symptoms. But on the other hand, it has a less of the side effect profile that a methylphenidate or amphetamine might have, and potentially might even be able to concur in treating somebody with anxiety disorder or with irritability, anger outbursts. So the non-stimulant can be more helpful with those predominant mood issues. Why is treating ADHD without making those issues worse? And other than that, for the stimulant medication, there's usually short-acting and long-acting version available. So usually ideally, I like to starting people off with a long-acting medication, or if down the road, eventually we want to be on long-acting medication, just because it's more sustainable. It's a one-time a day dosing in the morning, and then it lasting throughout the day, usually lasting, say, anywhere between 8 to 10 hours or 10 to 12 hours, depends on which medication you're choosing. So you don't have to worry about how to take a second dose, like the short-acting medication, which usually require only lasting 4 to 6 hours. So you might need a morning dose and a lunchtime, noontime dose. And it's not as sustainable because you're more going through a roller coaster hump. Sometimes we do short acting to start off if we're worried about somebody is very sensitive, metabolism. So we want to make sure they're able to tolerate it without suffering horrible side effects. So start with a twice a day short acting dosage before we convert to a long acting if we notice they are tolerating without side effects.
We have a couple of questions. How at home do we know if the medication is working, especially for inattentive type? How much change does it mean that it's working? Is there a way to measure this at home?
Yeah, so good question. So one part of it is, you kind of have to monitor how things are going and, make a comparison. So, there's no number to say everybody has to be a certain number of attention, right? But it's more like compared to your child without a medication and with medication, do I see an improvement? So sometimes we say you don't have to take the medication 7 days a week. You can take like 5 days a week. So you have a comparison of like, I'm on the same medication, same dosage for the 5 days when I'm on the meds versus the 2 days I'm not on the medication. Do I see a change in terms of the attention improvement? Another way to do that is, remember we talked about a Vanderbilt and a corner questionnaire earlier. So there is an initial parent-teacher report form. There's also follow-up report form. So sometimes your clinician can help you to monitor those data that after, say, 3 months, being on the medication, then you do a follow-up questionnaire again, and they can compare the data based on the observation from parent-teacher. Do we see a score improvement?
The other question is, can we give Ritalin in the morning and Guanfacine in the evening? Is that an okay combination?
Yeah, that is okay. So not specifically talking about Ritalin and Guanfacine, but just in general, it's very common that sometimes individuals need to be on a stimulant medication and a non-stimulant medication at the same time. They kind of augmenting each other for the ADHD treatment. Some people might, like we talk about, there might be other comorbidity or side effect that's going on. So they might augmenting the non-stimulant medication to mitigating some of the side effect risk from a stimulant medication that the stimulants was not able to touching or helping with. So that is completely okay. Especially most of the non-stimulant medication like Guanfacine or clonidine sometimes can be sedating. So that's probably why your doctor want to start those medication at bedtime evening to, avoiding sedation, but using a sedating effect, if anything, to help you with insomnia if that's already happening. And obviously Ritalin as a stimulant medication you want taking in the morning to actually helping you stay awake without causing insomnia if you take it too late in the day. So that's a completely okay combination. Okay, so in terms of side effect, so we kind of talk about for the stimulant medication, it can cause emotional disturbance, as I mentioned earlier, in terms of worsening irritability, anger, sometimes worsening anxiety, or some people say my child seems much more moodier, like there's more crying episode, stuff like that. So part of that you had to think about it is I always ask my patients' parents, think about the timeline, like what time of the day usually you notice those emotional disturbance. Do you notice there's all those emotional disturbance I just mentioned throughout the day as long as the medication are in your system? Then that could be a true side effect from the medication causing worsening emotional disturbance. Or somebody may say, no, my child's emotion is completely stable, fine, happy and calm, more efficient, more productive, getting work done until 3 p.m. or 4 p.m. I'm noticing him or her getting extremely emotional, moody, angrier, stuff like that. If that's the case, it might not be the medication directly causing side effect of the emotional disturbance. It could be that the medication effect is wearing off, like towards the later afternoon. So when people are crashing from the medication and the stimulant effect, that they're noticing the transition period, they're more moody, more irritable when the meds are wearing off. Or another way to think about it is, it's possible, like, is your child doing a lot of after school activities and say, okay, my child get off school at 3, and we immediately go to the ballet class or, the taekwondo at 4 p.m. And I notice around 3 to 4, he or her are extremely moody. So sometimes you have to think about medication. The stimulant medication can cause a physical side effect of appetite suppressant. So throughout the day, they might not be eating as much food as they used to. So when 3 or 4 o'clock, it might be the time their medication is even it's a long-acting medication, it might be weighing off, and their appetite is coming back. And it's a late afternoon, they about to do a lot of other gymnastic or other intense after-school activities. They're getting really hungry. So when they're getting hungry, they're getting more moody and irritable as well. So it could be a combination of the meds are weighing off and decreasing on the effect. And in the meantime, they are getting hungry because the appetite suppressing effect is also going down. So they are getting hungrier. And that's a combination also can make them more irritable and angry. So that in that case, what we need to do is to maybe adjusting the medication dosage or increasing the coverage of medication to give a more smooth transition instead of it's a medication directly causing a side effect of those, disturbance. So those are things you want to talk with your clinician about. Now, other physical side effects, other than the common one, the appetite suppressant I just mentioned, sometimes it can cause insomnia, which is why we usually tell people to take your long-acting stimulants before 10 a.m., the latest. And if you're taking, a short-acting stimulants, like an afternoon dose, don't take it past 2 p.m. because you don't want to take it too late in the day, which might cause insomnia issues. Other physical side effect is, sometimes people can feel too stimulated. It happens more when people are on a brand new stimulant medication or, during the dosage adjustment, when you just went to a higher dosage. Somebody having tolerance issue, your body's not used to the stimulating effect of the medication. So they can feel more shaky, jittering, have headache, dizziness, or feel my heart's pumping faster, things like that. Just imagine somebody don't ever drinking coffee and then today you're drinking like 2 shots of espresso. So, for the first time. So you might have this kind of overstimulating effect from the medication in terms of physical side effect. Some of those might go away after a couple of weeks, once your body is building on the tolerance, getting used to the medication. But if it doesn't go away and, your child feel I'm absolutely tortured by all the physical discomfort I'm going through, and it's not going away and it's continue or even getting worse. Same thing for the emotional side effects. Sometimes it get better after somebody being on the medication for a while, they're tolerating, but if it doesn't, after a few weeks, you probably should talk to your clinician and say, hey, I truly think my child cannot tolerate this medication. The side effect is pretty severe. We probably need to discuss some other options. Now, the last thing is in terms of alertness. So the stimulant medication in general is increasing people's alertness, which is why we talk about taking in the morning. So you can take advantage of the benefit from that to increasing your energy, motivation, stay more focused. You don't want to take it too late because, imagine what's going to happen if you drink your double shots espresso, at 8 p.m., right? You're probably going to stay out all night. And on the opposite, some of the non-stimulant medication tend to be somewhat sedating. So which is why we tend to taking those medication in the bedtime or evening time. So we can actually, for some kids, they have ADHD, they feel like, oh, I don't sleep because I have trouble to fall asleep because I have so much energy. So the sedating side effect might do them a favor in the evening to actually helping them fall asleep or maintain sleep better, that kind of thing. So we kind of take advantage of, the side effect profile to actually helping them with the needs they have.
Dr. Wu, can you tell the families about GenSight testing? I know that's something that we did with one of my kids, and it was just an oral swab. And the whole point of this testing is to identify the drugs that they can take for ADHD, anxiety, depression, any of the other alphabet soup in the mental health categories, and what they can take and what they can't take. And it doesn't mean that's what you prescribe, but it gives you a little bit more insight as to what might not work for the individuals. Can you share with them about that and what your thoughts are on that?
Yeah, that's a very good question. So the way I'm thinking about the genetic testing, is it's not a crystal ball to kind of predicting or guarantee you say, oh, I did this testing. The testing tell me exactly this is the medication my child should be on, will give me the best ADHD, treatment outcome. It doesn't work like that. So I don't usually order the genetic testing for all my patients who have ADHD. So it's usually I order that when somebody who has a failed 2 or 3 ADHD medication trial, or somebody who failed most, 2 or 3 medication trial because they had a side effect with different medications, then that's usually when we order it. What does the genetic testing do for you is to give you kind of like what Allison was saying. They can testing for, your child's metabolism response to a different category of ADHD medication. Again, not specific medication, but just a general category of different medication. Like we talk about methylphenidate category or amphetamine category or the non-stimulant medication category. What it tells you is like, is your child's genetic profile or metabolism tend to have are more likely to have adverse reaction with a certain category of medication. So which in that case, you might want to stay away from, or certain medication is more like a green light, like, okay, we're not showing that your metabolism system have any severe adverse reaction that's contraindicated to be on those medication. So it provides some like a rule out function to navigating you a little bit, be like, okay, if the genetic testing showing you're more likely to have a side effect or lower response with the methylphenidate category medication, maybe we should start you off with the amphetamine category, something like that. But again, it doesn't give you the crystal ball guarantee to say, this is it, that's the medication, will give you the best ADHD treatment. And
my experience with that, Dr. Wu, is that it isn't a crystal ball. You're exactly right, but it does give red, yellow, and green. Like red, like these medications by name should probably be avoided. And for us, I would say that test costs maybe $250, maybe $300. I think our insurance covered it. So it's not overly expensive. It's an oral swab for your child. And for us, it was pretty eye-opening because we had a lot of things that were on the red list that we wouldn't have known had we done that. And that's going to be the case for anybody. But just if you guys have had issues in the past with medication or you're wondering those things, it is out there. And typically your psychiatrist can order that. And it's GenSite testing, like Gene, GENE site testing. And you guys can look that up on the internet as well.
So there are a couple of major companies to do that. There's GenSite, there's also Genomind. So there are different profiles. Sometimes I personally feel Genomind actually do a better job than GenSite, but they both are really good mainstream companies out there. Again, based on the American Academy of Child Adolescent Psychiatry guideline, currently there's no standardized guideline to say that everybody who has a child with ADHD should get in a GenSite testing. There's no standardized guideline that's recommended by the American Academy of Child Adolescent Psychiatry to do so. So, but I know it's out there. And sometimes people do order it. I personally order it sometimes, but like I said, I don't feel it's something like, say, everybody with a headache go to emergency room should get an MRI brain. But it's more like if you have a specific clinical indication, like say, for example, like I mentioned, somebody who failed multiple trials of ADHD medication, then we'll be like, okay, we don't want to just throw more medication at you blankly without knowing what's going on. We need to look more specifically at your metabolism, why you're so sensitive, having so much adverse reaction with the previous medication. That would be an indication to getting ADHD testing from the genetic testing, to looking at the profile. Do you have a lot of medication under the red light? So what else can we try without keep giving you more side effect on the medication we're trying? So. Okay, so the last slide here is kind of showing a little more about in terms of the side effect profile for, stimulant medication. So this is based on a study that's throughout 16 years of a cohort studying longitudinal. They're assessing people's, growth in terms of weight and height for the patients who are on stimulant medication. And it could be any stimulant medication, not any specifically one. And they group them into either people who are consistent taking it. That means through the interval of, so they assess it for 8 times over 16 years. So basically once every 2 years interval. Are those patients taking the medication more than 50% of the days during the interval? That will be considered as a consistent. Inconsistent will be less than 50% of the days during each interval. And negligible means they're minimally taking, but they're still on the medication. And then the other ones, LNCG is a control group. It's just a community patient who don't have ADHD and never been on any medication. So the cohort study looking at a 16 years old span is showing that in the first 2 years for children who are on ADHD medication, they are potentially having a big dip in terms of the weight, which is kind of the appetite suppressant side effect we were talking about earlier, which is more in the short term. But once they hit the adolescence, hit the puberty, the patients who are actually consistently taking ADHD medication tend to have more weight gain in the adolescent or adulthood versus compared to the patient who are inconsistent taking it or minimally taking the ADHD medication. Versus from a high perspective, the patient who are consistently taking an ADHD medication tend to have decreased adult height compared to a patient who are either inconsistent taking it or minimally taking it. And that's throughout the time in the childhood and in adulthood. So what that means is it's possible that the ADHD medication is also delaying or suppressing the height growth. So those are things you want to talk about paying attention with your pediatrician and your psychiatrist, especially if your child is in adolescent and hitting the puberty, and to paying attention in their growth. Sometimes people confusing the weight gain once they're hitting the adolescency or puberty as like, oh, my child's gained weight back, so he's all growing back. But just knowing that there is a discrepancy of the height might continue being suppressed, although the weight might be gaining back during adolescence. Okay. That is it for this slide. So last slide is kind of the things we already talked about, in terms of other clinical comorbidity. So this is why it's important to getting a comprehensive evaluation by a psychiatrist or a clinician that, we don't just hyper focus on say, yes, my kid's jumping on and off the furniture, not getting good grades, must have ADHD, but maybe your child is having ADHD, but in the meantime, we want to make sure we're not missing any other comorbidity in terms of anxiety, depression, anger, or emotional outbursts. We talk about, other neurodevelopmental disorder like autism that Alison mentioned earlier, any other specific learning disability like math or reading, something like that. So we want to make sure we're taking all those into picture, because that kind of helping us to guide and navigating what type of medication option will be a better choice for my child. Depends on how many other comorbidity that's going on. And is there any other additional behavior intervention or psychotherapy might be necessary in terms of emotional regulation as well when we are treating the ADHD symptoms. And if you do have a learning disability, then, medication is not going to just magically resolve the learning disability. You might also want to consider talking to school, getting more school accommodation and tutor, academic support to helping with those kind of deficits as well. And the other thing is, relationship conflicts or, academic performance issues. Those things should also be, taken into consideration when we are proceeding with the ADHD treatment. Okay, so we have about 7 minutes left. So I want to see, that was a lot of information in a nutshell. I want to see if there's any questions from the audience.
Is there a strong correlation between ADHD and social skills, also crossover between ADHD and high functioning autism?
Okay, so that's two very big questions. So I think, to answer your first question, yes. So sometimes as, people have ADHD, a lot of time when people asking me, my patient asks me, does my child really need to be on medication? Or can I just be in therapy doing behavior intervention? I tell people to think about three major domains that can be affected by ADHD. One part is interpersonal relationship in terms of, are you getting into a lot of fights with your siblings, a lot of fights with peers or parents because of the social emotional impulsivity, leading into more short fuse, mood swing, and anger outbursts, which can be the social skill you're talking about. Sometimes people say, people don't want to play with my child because he's so impulsive or impatient, or fighting back too quickly, right? So that could be the social skill issues that you were talking about as a secondary issue due to the primary ADHD. And in terms of the high functioning autism, so this, for today, we're not talking about autism, right? But just to let you know, so for somebody who individual really do have autism, usually ADHD is a number one most common comorbidity for somebody with autism. So I wouldn't be surprised somebody have both issues. but not saying everybody
Then
does.
Yes. And I know that in my personal practice, we do see a lot of the comorbid with the high functioning and ADHD, and there's a lot of other things that go along too. But someone asked, is there a correlation between epilepsy and ADHD? My daughter had a few seizures and then her focus, cognitive skills got impacted and then diagnosed with ADHD.
That's a good question. So when somebody has like a medical comorbidity like epilepsy, so it gets more complicated, right? So this is when the neuropsychological testing will kick in place, because the neuropsychological testing, just as the name sounds, it looks at neurocognitive aspect of your functioning. So for somebody who had a brain injury, or a seizure, those kind of issues, it will be more helpful to looking at both set of issues to see did the seizure or the other kind of brain, organic brain etiology can lead into not able to focus, or your working memory or other part of the neurological effect. So you will probably need to be closely monitored by a neurologist as well, because we don't want the ADHD medication making the seizure worse either. So.
For sure. Is there a benefit to taking ADD medication through adulthood?
So ADHD medication can be taken in childhood and it can be taken in adulthood, or sometimes both. So part of it is that we want to encouraging people to also learning concurrent, from therapy skill, behavior intervention, learning better of task organization, time management, how do I not be so fidgeting during my working conference? But, behavior intervention will be important to cope. But in the meantime, for a lot of adults, they do need ADHD medication to remain, good performance with your work and a relationship issue as well. So it's definitely not contraindicated to be on ADHD medication in adulthood.
And then also, in this meeting isn't about that, but of course there's different types of therapy, the CBT, cognitive behavior therapy, and the dialectical behavior therapy. There's different types of therapy that can be effective as well. One person says, if a child took the ADHD stimulant medication for a year and stopped, does the child's height, adolescent, begin to reach their normal height level? Height was a concern for our adolescent.
Yeah, so that is possible. Again, I cannot say guaranteed, because everybody's there's other medical reason can leading to your height growth or genetic reasons. But if it's a purely medication side effect causing the halt or delay of the height growth, it is possible once you stop the medication, those side effects will go away, just like the appetite suppressant will go away. Then you will, resume your normal growth rate as your own individual. So.
Okay, we have another question. I love that you guys are putting the questions in the chat box. These are great questions. How do you know when it's time to reassess the dosage and consider increasing the dosage? Are there specific signs you would recommend to watch out for?
Great question. So we usually recommend, for psychiatrists to see your child in a regular base. So, either once every month, every 2 months, or 3 months, but you want to have regular interval of, psychiatry appointment with your psychiatrist or your pediatrician, whoever is prescribing the medication. So you don't want to wait for too long, like once a year or something. Because one is, symptom might change, the amount of external stress might be changing. So that can lead into worsening of your symptom. And another part is a lot of the ADHD stimulants are weight-based medication. So if you're talking about a little child who is now like hitting puberty or like going through a growth spurt, it's possible certain medication previously working pretty well. Recently, you find out from a teacher or parents say, hey, it's not working as well as it used to be. So I would say keeping close touch with your teacher to getting feedback of how things are going at school. As a parent, you will see if any change in terms of their performance and behaviors, and then, regular appointment with your psychiatrist or pediatrician to discuss like, how are things going lately? Do we need a dose adjustment? It's not a set time or set dose change for every individual, because everybody's different, right? But you do want to have a regular monitor to adjusting the dosage and treatment accordingly based on your child's symptom.
And I would say too, I have an adult, right? So we've kind of transitioned into adulthood. And I would say even keeping a little log, because life gets busy and you live with this kid, right? So sometimes sometimes things slip through the cracks, but those big mood swings or unexpected meltdowns that don't normally happen, or other things that are happening, like you said, connecting with the teachers and stuff, all of those things are good things. And having a little notebook, because especially if it's, 2 months or 90 days before you go back to the psychiatrist, keeping track of these things so you can recollect when you get back to your appointment, I think is also important. Last question, and then we've got to wrap up. Can you compare Adderall versus Vyvanse for long-term use?
I think this is going to be a very specific question. You have to talk to your clinician for the individual who's being treated with medication. They both are high potency amphetamine category of medication. They're kind of like cousins. So depends on, some people have better responses one versus another, but you cannot have to talk about that, individual to individual base. So.
Okay, one last question, because this is a good one, and inquiring minds want to know. Can you take stimulants to treat ADHD your whole life? Is that safe?
So it is possible for some people need to be on ADHD medication for a long time. I cannot really say you had to be on for a whole life. It's more like a personal preference. You want to be closely monitored by your doctor to make sure you're not over medicated, that you don't need to. If a lower dose can do the job, lower potency medication can do a job, then try to reserve the higher potency or higher dosage for later, because there is a risk of building up a dependence and addiction issues with medication. But with a close supervision, you kind of mitigating any of that risk, right? So, and in the meantime, learning behavior intervention, coping skills with your time management, task organization, impulsivity issues will also be helpful. If you are concerned that I don't want to be a life sentence of ADHD stimulants, then gain more life skills and coping skill to deal with that, will be helpful to reducing the chance of you have to continue to go to higher and higher medication. So.
For sure. Dr. Wu, a lot of times families do struggle to find a psychiatrist that they can work with. Are you accepting new patients? And are you private pay, or do you accept various forms of insurance? Can you tell us about if you're accepting patients? Because I'm sure that people might need your services.
Sure. So yes, I am currently accepting new patients, and in general, we can get a new patient scheduled within 1 to 3 weeks. And for the initial appointment, it's usually a 90 minutes initial diagnostic consultation appointment. Like we talked about, we want to make sure we understand the diagnosis before we proceeding with the treatment. So I don't take insurance, unfortunately. I'm a cash pay only private practice. The service fee chart is on my website. If anybody who's interested in schedule appointment, you can visiting my website, which is listed on the slide. And there's a new patient tab. You can fill an online pre-screening form. And we're always providing all the prospective patient with a 15 minutes of free phone consultation to touch base, make sure we both are a good fit before we're helping you with scheduling.
And I just want to mention, while there are some psychiatrists that do accept insurance, most are private pay. But I would just say that there are out-of-network claim forms that you can submit on your own and get some of that reimbursed. And I've had a lot of success doing that over the years. So don't let that be a huge factor of deciding to reach out to or not reach out, because there is such thing as out-of-network coverage. You just have to file the claim manually is basically how that works. Guys, we're out of time for tonight. Dr. Wu, it has been absolutely my pleasure in hearing you talk tonight. This is such an important topic, and it's a real struggle for a lot of parents. And so thank you for sharing your information. We will be happy to have you back and to speak with us again. Thanks, everyone, for attending, and we will meet again next month, the first Tuesday of the month. You guys will get an email with her slides from today and the recording. So thanks so much, everyone. Have a great evening.
Nice to meet you. Bye-bye.
Bye now.